Hello and welcome. My name is Dr. Ryan Avashu. I'm a PGY3 in the internal medicine program here in Calgary. I'm bringing you this presentation, an educational intervention to bring you up to speed on a new quality improvement initiative on the MTUs here in Calgary, specifically handover using the iPass system. So, before we get started, no conflicts of interest to disclose. I will, however, mention you may hear my lovely bulldog Gibson snoring in the background while I record this podcast. Here's what we're going to be going over today. We're going to talk a little bit about the project, some accompanying research, and we're going to talk specifically and focus mostly on handovers, the iPass system, how to use it, and specifics to using it here in Calgary. So let's start off with an overview of the project. So the project is the implementation of a formalized handover amongst MTU residents. There will be an accompanying research that will be focusing on overnight call. Specifically, the research will aim to determine if formalized and structured handover has an impact on anxiety and confidence when compared to our current unformatted and unstructured handover process. This project had the support of our program director, Marcy Mintz, our internal medicine chief residents, as well as the medical teaching unit medical site leads at the Lougheed, Foothills, Rocky View, and South Health campus. Let's touch a little bit on the research component that will be attached to this quality improvement initiative. So the research aims, as I mentioned, to determine if formalized and structured handover has an impact on anxiety and confidence when compared to the current unformatted and unstructured handover process that you currently would likely encounter on the MTUs here in Calgary. What will this involve for you? There will be a pre and post survey that will be emailed to you before and after your call shifts. We'll ask you to complete this survey. It's a SurveyMonkey link, so all you have to do is finish it. Should take less than 5 minutes and submit it. And there'll be a post-intervention, semi-structured interviews for selected PJY1s. You may be contacted and offered to be involved in this process, and of course you have every right to decline, but we'd love to have your involvement. So let's spend the majority of our podcast talking about handover and specifically the iPass system. Starting off with an introduction to iPass. So why was handover developed? When we look at the root cause of sentinel events being adverse or negative events that typically have a negative effect on patient care and a potential for morbidity and mortality related to that patient. As with most things in medicine, sentinel events are multifactorial. However, time and time again, when we look at the most common cause and the most common root cause of sentinel event, we see that communication is more often than not at the top of that list of things that leads to sentinel events. So, when we look back to handover, we know that handover is the transformation of information and responsibility. Handover does occur during transitions in care, shift change, end-of-block service, unit transfers, discharges. Of note, we're going to be focusing on handover at shift change, more on that in a bit. And handover is a common event. There's a significant amount of communication that happens during handover. Thus, there's a high risk for sentinel events to occur. Thus, handover and handover done properly is of the utmost importance for quality improvement and patient safety. That brings us to what are the key elements of handover? Those elements are as follows. Unambiguous transfer of information and responsibility. It's obvious who's responsible for what. Protected time and space. With regards to our MTUs here in Calgary, that means end of shift, typically sometime between 16 and 1700, more on that in a bit. And the space would be your MTU team room. Standardized format. In our case, that will be the iPass system. Again, more on that shortly. The importance of leader and assigned roles, and both verbal and written elements for handover. So that brings us to iPass. What is iPass? It's a standardized and structured handover tool. It involves verbal handover, which is guided by the iPass mnemonic, and written, or in our case, typed handover, which is also guided by the iPass mnemonic. Verbal handover is in a structured format. It happens in an appropriate place. Again, this will be your MTU team room. It has closed loop communication. This helps to create a shared mental model amongst the team and the individual receiving handover, typically another team member. who's on overnight call, and facilitates appropriate discussions and questions amongst the team and the team member getting handover. Printed handover supplements the verbal handover. It allows the receiver to follow. Think of this as, instead of taking all of your time and attention writing everything down, all of the key elements are already written down for you, and just a few very specific or additional notes can be made, and you can focus on following the information and not having to write. And it also provides more comprehensive information if required. Why iPass? It's a standardized system that focuses on communication. It is well proven, researched, and very well established. It also has proven effectiveness and a proven track record. And specifically in the medical literature, it's been shown to decrease negative patient outcomes and have a positive impact on communication amongst healthcare practitioners and specifically amongst residents. So, why iPass? Handover, specifically for our intensive purposes, end of shift handover, is a major time for information transfer, thus, as we've touched on, a major potential for sentinel events. Implementation of a handover tool helps to standardize communication, and our hope and goal is that with the standardization of this communication, we will reduce the number of sentinel events for the patients we care for on MTU. Why the iPass mnemonic? It's a memory aid. It's easy and simple to remember, and thus it is more likely that you'll actually use it. It uses a standard language, thus creating a shared mental model so we're all on the same proverbial page. It follows a sequence, the same on each and every patient, each and every time, again helping to create that shared mental model. And lastly, it focuses on key elements and focuses on those key elements that the resident on call overnight needs to know in order to give the best care. So let's talk a little bit about how to use iPass and specifically how we'll be using it here in Calgary. The mnemonic iPass: I, illness severity; P, patient summary; A, action list; S is situational awareness and contingency planning; and the last S is synthesis by the receiver. Let's go into each of these in a bit more detail. This is a copy or an example of the iPass information lanyard you'll be given to put in your ID badge. Copies of these will be available on the MTUs you're working on. Illness severity. So this is the focal point for the beginning of each patient report. We use a standardized language, stable, watcher, or unstable, to help facilitate a shared mental model of the overall global picture of each patient that you're reporting on. Let's go into these labels in a bit more detail. The first is stable. So what makes up a stable patient? You probably already know this, but let's think of some specifics. Vital signs, physical exam has been stable, labs and or investigation stable. Typically these patients are differentiated or moving towards being differentiated. Typically a diagnosis has been made. It doesn't have to have been though, and treatment is initiated. These patients have a clear disposition and plan in place. This would make up a stable patient presentation. Next is watcher. So what makes a patient a watcher? This is any patient you're worried about. You have that gut feeling or gestalt that this patient may get sick. There may be some variance in vital signs or physical exam findings. There may be some variance in labs. The patient may be somewhat undifferentiated. A diagnosis may or may not have been made. Treatment may or may not have been initiated for that specific diagnosis. And this is any patient you are worried will get sick or get ill during the course of your shift. This is a patient that will be labeled a watcher. And the last is unstable. So this is any patient who has unstable vital signs or physical exam findings, unstable labs or investigations. They're undifferentiated. A diagnosis may or may not have been made, and specific treatment may or may not have been initiated. This is any patient that is going to require frequent attention, monitoring, or specific care over the course of the night. And another way to think of this is a patient who may require a code 66 or an ICU consult and a transfer to an additional or a different service. This would be the unstable patient. So begin each handover on every patient with an illness severity label. Ensure that each patient has an illness severity label on SCM. We'll go over that shortly. And again, remember, every patient is labeled as stable, watcher, or unstable. Patient summary. So why do we do the patient summary? There's a lot of benefits. It's an essential clinical skill. It requires a structured approach, practice, and feedback. The practice and feedback you're going to get by being able to do this multiple times throughout the course of your MTU. And what are the benefits of a high quality summary? It helps to create a shared mental model. It facilitates the transfer of information and responsibility, transmits information concisely, and helps to describe any unique features of a patient's presentation. So what does the patient summary include? Every patient summary will have an ID, HPI, hospital course, and assessment of plan. Let's go over each of these components of the patient summary in a bit more detail. The ID. This is the one-liner you often hear referred to. This includes the patient's name, age, gender, pertinent medical history. Notice that's underlined. A patient may have 15, 20, 25, or 30 different pieces in their profile/medical history, but here in the handover, in the ID, you only want what's pertinent for that presentation and the most high yield information. And lastly, reason for admission. This can include symptom, diagnostic test, investigation, or clinical syndrome. History of present illness. This is a brief, and again, underline brief, summary of the events leading up to the admission. This can include the HPI, any essential history or physical exam findings, and or essential exam or lab findings. Again, these do not all have to be included, just those that are pertinent for your handover. Course. This is going to be the hospital course, key events and updates, and there can also be highlights of special considerations such as family, social issues, nursing concerns, and chronic medical condition concerns. This is to give a brief 1 to 2 line of the patient's course in hospital to bring someone up to date on how the patient has progressed during their stay. And last, we have assessment and plan. This will usually be the bulk of this part of IPASS. This usually includes assessment, major active issues. This will be a symptom, diagnostic finding, or diagnosis, and then the plan for each one of these assessments. This is a, again, brief, and I underline brief, description of the management, and can but does not have to include workup, treatment, monitoring, follow-up, consultations, etc. Basically, for each assessment/issue, what is the plan? And again, keep this succinct so that a person overnight just has the most crucial and vital information. And I've spoken a bit about this, but let's touch in a bit more detail. The level of detail required will depend on the patient's complexity, the patient's length of stay in hospital, and the receiver's familiarity with the patient. Knowing that when the patients are complex, have been in hospital longer, and or the receiver is not as familiar with the patient, summaries may end up being a bit longer. Although those patients that are a bit more straightforward with shorter stays in hospital and or are well known to the receiver typically can be much shorter in length. So, patient summary. Let's do a few examples of the patient summary. ID, 37-year-old male, no previous medical history with a 2-week history of NSAIDs. So let's do an example of a patient summary. This would be what you'll be typing into SCM, which we'll go over here in a moment, as well as gives you an example of what this will sound like when you give the verbal report to the receiver who's on call overnight. ID, 37-year-old male, no previous medical history, 2-week history of NSAID use, presenting with upper GI bleed. His HPI has, as mentioned, 2-week history of NSAIDs post-knee injury, presented with hematemesis and melena, hypotension and tachy. He's been fluid responsive. His course in hospital, he's received 2 units of packed red blood with fluid resuscitation. His vital signs are normalizing, and he has a PPI infusion. GI has seen him. Assessment and plan. Upper GI bleed secondary to NSAID use, PPI infusion, fluid recess PRN, and transfuse if his hemoglobin falls below 90. GI to scope in the AM. If he becomes unstable, call GI. Issue 2, hypotension. Secondary to GI bleed, monitor, fluid, and packed red blood cells as required. Let's do another example, maybe a bit more complicated. ID, 64-year-old gentleman with a history of ischemic heart disease, coronary artery disease, COPD, he's actually on 2 liters of HOMO2, smoker, and poorly controlled type 2 diabetes, presenting with left lower lobe pneumonia. HPI, 10-day history of upper respiratory tract infection that progressed to productive cough with shortness of breath, increasing O2 demands, and fevers and chills. At admission, he had worsening respiratory distress slash hypoxia, which is now resolving, secondary to his pneumonia. Also found to have hyponatremia and an AKI in presentation. His course, decreasing O2 demands on 3 liters nasal prongs. Infectious workup has been negative. He's responding well to treatment of his left lower lobe pneumonia. Assessment and plan, hypoxemia. His CTPE was negative, no other underlying pathology, consistent with a left lower lobe pneumonia. He's on ceftriaxone and azithro for 7 days. Hyponatremia, secondary to hypovolemia. This is resolved, and his AKI was prerenal, also resolved. So again, remember, when you're doing the patient summary, appropriate time spent on each patient. Remember that the level of detail and level of time, as we've said before, will depend on patient complexity, length of stay in hospital, and patients that are known versus unknown to the team or receiver. Action list. Think of this as your to-do list. Should include a timeline, level of priority, clearly assigning responsibility. For us, this is more straightforward because we're assigning responsibility to a single team member, but still important. And indicators of completion. Important though, don't make things up to do. Doesn't need to be anything to do overnight. If there are no action items anticipated, both in your verbal and written reports, clearly state nothing to do or no anticipated issues. So a few examples, as you can see here. Check respiratory exam now and Q4 hours overnight. Check fluid status and lights Q4 and PRN. Follow up hemoglobin at 1800 and 2200, and follow up on blood culture results. Again, these are examples of potential action list items. If you had nothing that was required with your patient overnight, you can simply, as we said in the previous slide, say nothing to do and or no anticipated issues. Next, we have situational awareness and contingency planning. So situational awareness, what is this? This is the proverbial and literal know what's going on around you. This is the status of your patients, team members, environment, and progressive towards team goals. What do I mean by this? This helps the learner/receiver overnight know the status of the patients, what team members are involved, can be involved, or can be relied upon, the environment and things that can be used to help with patient care, and progressing towards team goals. Read as things that have and have not worked can be brought up during a report to help the person on overnight be aware and not trying to re-implement strategies that have been tried and failed before versus trying things that have been implemented and succeeded before. Other important situational awareness things that can be brought up in very specific circumstances are difficult family or psychosocial situations, as well as specific nursing or family concerns. This is critical for patient safety. It helps to provide the receiver with instructions, specifically instructions regarding adverse events or adverse anticipated issues. It ensures that the accepting team member is prepared to anticipate changes in status and how to respond to those potential changes. That's the most important part, and that is what contingency planning does. A bit more on awareness and planning. It helps to also articulate what might go wrong and helps to define the plan, as we've talked about. Listing interventions that have or have not worked speaks to this with regards to code status and helps to identify resources and chain of command. Specifically, examples here could be calling the senior medical resident, calling a specific resident on a consultant team, or consulting a colleague in ICU, or calling a code 66. And similar to as we've talked about before, the level of detail will be based on the level of experience of the receiver/provider overnight, knowledge of the disease process, and familiarity with the service and or the patient being cared for. So some examples, going back to our previous to-do list, if we think of that respiratory exam, instructions could be, if it's worsening, give additional Lasix, and not responding, call a code 66. Check fluid status and lights. If not improving or worsening, fluid bolus PRN. With regards to the hemoglobin, transfuse if the hemoglobin gets under 70, plus or minus call GI if unstable. And following up on blood cultures, call and review with the senior. If need to start blood cultures, would recommend piptazo. And last, we have synthesis by the receiver. So this is a brief restatement of essential information. Demonstrates information demonstrates that information is received and understood, and ensures effective transfer of information and responsibility, and again helps to promote the shared mental model. Of note, this part, specifically synthesis by receiver of the iPass system, was designed for team members taking over a team that they knew none of the patients. So for our circumstances, where on MTU we typically have at the very least heard, if not met, every single patient, this again will not require as much detail and can simply be a no questions next patient, and does not need to have a full detailed rebrief of essential information. And I've spoken to this here. It will vary in length and context. More complex or sicker patients will require more detail. At times, this may focus on action items and contingency planning. Specifically, if there is an anticipated issue and the receiver is unclear on what the plan is, this is the perfect time to bring this up. And it helps to address priorities for individual patients. And this is of the utmost importance. It is not a restating of the entire verbal handoff. It's simply a one or two liner if required. And what is more oftenly going to be done is the receiver can simply say, no questions, next patient. So that's the iPass system. Let's talk about some Calgary specifics. So this is the SCM patient list that you'll typically see. As you can see here, this was made when I was on Foothills Medical MTU Blue. So you'll come to this screen, patient list tab. From there, you'll select your patient. You see here I've selected a patient in blue, and you're going to click the patient info tab. This will bring you to the following screen. You'll see on the left hand side summary views and data entry. Under summary views, if you click health issues, you see that here highlighted in blue, you'll see the sign over tab. And specifically here, you'll see the May 30th watcher. This is where I want you to put the illness severity indicator along with the date. This tells us two things. Again, one, when this was last completed, so you can track and know how up to date this is. Again, ideally, this should be done every day on every patient. And it gives a quick, very succinct overview of the patient's status by indicating the illness severity. And again here. So what happens if you get to this page and you don't see the handover sign over tab? Next thing you do is go down to data entry. You'll see health issue indicated by the green arrow here, which will pop up the following screen. Of note, if the sign over tab is already here, if you double click where the green arrow is, this will also bring up the following screen. It'll look like this. Going back. So no sign over tab, we hit the health issues tab. Brings this up. You'll see just down here, sign over. I want you to double click that. And then it'll bring up the following box. Here is where we enter the date and our illness severity. And then in the description, we put our ID, HPI, course, assessment and plan, and to-do and plan list. Ensure that once you've populated all this information, you've saved your changes. Of note as well, what you see in the description box, the ID, HPI, course, assessment and plan, and to-do and plan, is not automatically populated. So if you're putting in this information, you're updating handover for the first time on a patient, you will have to populate this. Last thing you're going to need to do and want to do is print. So you're going to go back to your main screen and you're going to hit the print icon and you're going to select the handover report medicine/pediatrics 2015 option, and this will give you a wonderful printout with all of the patient information as well as your handover that you. Alright, and the last few Calgary specifics. So come prepared. What do I mean by this? Ensure that you're typed handover on SCM is completed prior to starting handover. Why? You want the person who's on overnight to be able to print off a list that is up to date and has everyone's typed handover completed. Where? You're going to be meeting at your MTU team room. When? This will happen at the end of the day. Now, this will depend on your team, how busy you are, etc. But as a general rule of thumb, the MTU day finishes up around 1700. So you should plan to do handover around 1630. Your goal should be to have handover take no more than 30 minutes. And ideally should be taking 15 to 20 minutes. I do anticipate the first few times you do this, it will take longer, but once you get the handle on it and get proficient at it, you can easily do handover on 20 to 25 patients within 15 to 20 minutes. And who? All MTU team members. As this is a resident-led initiative, the focus will be having senior and junior residents at handover, as well as clinical clerks and medical students. Attendings do not have to attend, but of course are highly encouraged to participate and attend. All right, so that concludes the presentation. Here's a few references, some information on the IPASS system and IPASS study group, some membership of additional IPASS member committees, IPASS participating institutions, IPASS funding information, and that's all. Thanks for listening. As I said, if you have any questions, please feel free to email me at either of the two emails below, or if for some reason you need to talk to me immediately, I can be reached via pager at via the AHS paging system 06381. Thank you for your time and attention. All the best on your upcoming MTU rotation.